So today is a conversation. You have some background on who's here, but I can tell you that Dr. Lee Sachs, who is Advocate Healthcare's Executive Vice President for everything, or pretty close. And last night he had a long conversation with Barry McClellan, and I just have to tell you one little issue. He had a little bit of surgery done, and the only thing Barry wanted to know was the age of the surgeon. So something twigged. I thought that was very interesting. So, then we have Kaveh Safavi, who is the, I'll probably get it wrong, but he's the Managing Partner Healthcare for North America for Accenture. Close enough? Thank you, Kev. So here's what we're going to do. These two are going to start a conversation, unrehearsed, although they probably talked about it a bit, and then we'll move into the crowd. And if anybody wants to ask any questions about the Time Magazine article, you're more than welcome to do that. Kev, go for it.
I'm very pleased to have Lee Sachs here with me. Lee and I, by pure coincidence, really, we've been friends for about almost 20 years. We were both much younger and much smarter back then. At least we thought we were. I'm going to ask Lee a little bit about himself, but also about what's going on at Advocate. Advocate is the largest accountable care organization right now in the United States when you consider all the different things going on. I know many of you understand or have been reading about that, but we'll talk a little bit about what that means and then some of the lessons that they've learned, and we'll go from there. Lee, thank you for coming. Why don't you tell us a little bit about yourself, your journey here professionally, and let's get to know you a little bit personally.
Okay, well, good morning. I'm delighted to be here. Had a lot of fun last night. You know, I always aspired to go into healthcare. My mother was a nurse, my father was a pharmacist, but my journey started, I trained to be a chemical engineer and was going to go into biomedical research. And when I went to medical school, I fell in love with patients, and I ended up being a family physician, primary care doctor. I practiced 13 years in a two-person practice in the suburbs of Chicago, and I started to get involved with our managed care organization as capitation was coming in the early 80s. And one thing led to another. A half a day a week as a part-time medical director over a couple of years led me to be running a physician hospital organization at our local hospital. And we were caring for probably 40,000 prepaid lives. And then I got enamored of that opportunity, and they asked me to do a few more things, and pretty soon I had to step out of the practice because I felt like I was doing two full-time jobs. That was back in 1993. And the next year, the planning came along to create what's now known as Advocate Healthcare. It was kind of on the backside of the failed Clinton healthcare reform, but everybody was thinking that you had to create a delivery network, and scale was going to be important. So our hospital merged with another organization that was 5 hospitals, create Advocate Healthcare, and I was asked to put together a care management and managed care contracting organization. We started with about 1,000 physicians and had 90,000 prepaid or capitated lives in 1995. We grew to over 400,000 capitated lives, and the physician network continues to grow and is now a little over 4,000. But around 1999, 2000, we stepped back and did a strategic plan and said, in spite of our success, capitation really wasn't going to become the predominant payment mechanism in our market. It just had a bad image. The medical society had really, just gone out of its way to say we don't like it because the rank and file were uncomfortable. And we said we need to do this in a fee-for-service environment. And in order to legally negotiate on behalf of a group of physicians who in our country are considered to be competitors because they're all separate businesses, you have to be clinically integrated. And we set out to do that through metrics and a pay-for-performance program. And I spent 4 years under investigation by our Federal Trade Commission as the major payer accused us of antitrust violations. And We could have folded the tent, or I could have ended up behind bars. And the really exciting news is that we really educated the regulators, and at the end they came out and signed a consent decree that said that our model could continue. And actually on the plane yesterday I read an analysis that one of the directors who had been involved in our case just issued that allows another organization to move forward that's clinically integrated. And it was kind of unprecedented, so I smiled and said it still is working, that they actually see the potential value of a group of doctors and hospitals working together to improve care. So today, Advocate Healthcare, we're 11 hospitals, 9 are in Metro Chicago, 1 is in a farming university community of Bloomington Normal, and the last one is what we call Critical Access, 25-bed hospital in Eureka, Illinois. Claim to fame, that's where Ronald Reagan went to college. And you know, everybody there still talks like they were around when he went to college with that. So we've got the challenges of a very small hospital where almost everybody who's really sick needs to be transferred to 3 large teaching hospitals. We're almost $5 billion in revenue with that. And over the last 3 years, we've really built upon our journey with integration to move into pay for performance under the Accountable Care Organization. We started ahead of the federal government and signed a contract that went into effect in January 2011 with our largest payer. It's probably the largest shared savings contract in our country. We have accomplished our goals of improving care by enhanced outcomes, lowering the cost of care, and growing market share, but it has been a fascinating journey. We're learning every day, and the payer is too. It was a lot harder to manage and get the data that we needed than any of us imagined, and we're participating in our federal Accountable Care Medicare Shared Savings Program. We have 106,000 Medicare lives. That makes us the largest participant. That started July 1, and through the wonders of our government, we still don't have any data, but they expect us to be able to manage and change the care for those patients. So it's going to be an ongoing journey and lots of learning.
Great. You have some teaching programs as well. Can you talk a little bit about that?
We have 3 teaching hospitals in Chicago has 7 medical schools, and we have formal affiliations with 3 of them. We have about 600 residents and fellows across our hospitals and students from all 7 of the medical schools. So a real culture of teaching and research and wanting to stay on the leading edge.
Great. So the terminology accountable care is used a lot in the United States as an organizing principle, and I wonder if you could talk a little bit about what that means, what it means to advocate, and your current strategy in terms of that political conversation that's going on.
Yeah, we've actually tried internally not to use the term accountable care or ACO because it's really a political term that grew up in the Obamacare health reform discussion, and what it really stands for is that the delivery system needs to be accountable for the quality, the service, and the cost of care, the so-called triple aim. And our feeling is that regardless of how we get paid or what you call it in terms of nomenclature, those are the things that we need to do to be successful. We've always been on a quality journey. We've gotten very serious about taking costs out. Over the last, I think, 3 years, we've taken 2% of costs out across the organization, but I like to look at costs as what's the cost of delivering care to the population, and that's a different equation, and utilization and complications factor in, and we're doing much better than that with it. It's not a secret that our country faces a huge economic crisis, and it's really driven by healthcare. Healthcare inflation has far outstripped the growth in the economy, and I think most people now will acknowledge that that's unsustainable. Unless you're within a couple years of retirement as a healthcare leader, you can't ignore it, and if you can't figure out how to fix it, your career is going to be at a dead end.
Great, thank you. So let's talk about clinical integration. You used that term. You said that when the doctors were being potentially prosecuted for antitrust, that it was the concept of clinical integration that was their defense. What does clinical integration mean in terms of who has to participate, and what are some of the levers that are used to start accomplishing that?
So the definition that we've used is that it's a partnership between and among physicians and hospitals to enhance the outcomes and create value. And it's really an ongoing process. It's not that here's the template and if you do this. It's been a journey. We started off very small, but we needed to have a set of shared metrics and some common incentives. And we basically looked at what are the high-cost conditions, and it's not rocket science. It's diabetes, it's congestive heart failure, it's pulmonary problems like asthma and COPD in the adults that drive a significant part of the expense. And we said, rather than looking at just an acute episode in the hospital, what are the things that can help these patients lead healthier, more productive lives, and over the long run is going to save money because you're avoiding the complications of end-stage diabetes or end-stage heart failure. In the first year or two, we took a lot of process measures. I was kidded a couple weeks ago that some of my team remembers the meeting that we had after we were served notice that we were going to be investigated, and I called the group together and I said, we have to execute on this, and we have to be able to demonstrate that we truly are integrated, because otherwise we're out of business. And everybody's eyes widened, and they all started thinking about what they were going to ask in terms of resources and staff and IT. And I looked at them and I said, and we can't do this with any increased resources. And we actually have to be more efficient. And we were able to do that. So we started with data that we had access to, because manual chart review is the bane of everybody's existence. And we didn't have electronic records back then, 10, 12 years ago. And then what we would do is we'd put a set of metrics in place. And in the beginning, we had a very small incentive fund that we distributed at the end of the year based on the physician's performance on the metrics. And each year we refined the metrics and added to them, and we moved to true outcomes measures. So the first year it was how many diabetics had their hemoglobin A1C measured and had eye exams, but now we're saying how many have hemoglobin A1Cs below 7 and how many are above 9, and is their LDL cholesterol below 100, and the intermediate outcomes that presumably are going to lead to fewer cases of renal failure and vascular disease. The dollars grew every year, so it got physicians' attention. One of the early comments was, this is extra work or hard work, and yes it is. And most of the things that they needed to do, which really revolved around better communication and education and behavior changes, we don't pay for. There's no codes for that. So we quickly connected the dots and said the check that you get in April makes up for all the work that you did in the prior year. And certainly for our primary care physicians, they got it, and it was a substantial boost to their income over the years. And I would say by year 2 to 3, everybody started talking about the pride they had in improving outcomes for our patients. And I got the sense that the flywheel was spinning and had momentum on its own, and that the dollars were less and less important. Of course, nobody turned them away, and for those who didn't do well and the check was small, there was always a conversation about how come and this isn't right. But the professional satisfaction about the improvements, and we started to publish an annual value report. He's got the latest one here. It's online. Because we felt that we had to educate the large employers and the payers. So this is targeted at the benefits people in large employers, and it's written about the economic value. I mean, yes, we have the numbers about hemoglobin A1C, but we translate that into lost days of work avoided, absenteeism, presenteeism, and things like that. And we went out and met with the employers annually, reviewed it, and always said, what's missing? What would be helpful for your workforce that we're not doing? And that, in the early years, helped us evolve a little bit, but it also neutralized the payers, because when we would sit down to negotiate, and we have 6 payers that collectively are almost 98% of our commercial market, but one of them is 70%, so they're the dominant. And none of them collaborate. You know, they all want to improve diabetes, but they all have different goals and measures, and that drives physicians crazy. And back in the days when I was practicing, we basically ignored it. And at that time, you were at a payer, so that's when we first met, because it was impossible to worry about, is Mrs. Jones with the Blue payer, or United, or Humana, or whatnot. And the reality was, as I came to see, the patients stayed with their physicians a lot longer than they stayed with an employer or with a payer. And if you couldn't manage them over, you know, a lifetime, you were sub-optimizing it. So when the payers would say, well, gee, our corporate office says we need to do this, our answer was, these are the things we're doing, and you know, we can meet your outcome needs, but we're going to do it our way. And that really separated us from a lot of the other networks in our market, and it was a win for physicians because it decreased the hassle factor. So we update this every year. The new one will be out in April with our 2012 results, but it was our first foray into transparency, and this is aggregate across the whole network, showing our results, and almost all of them have improved year over year, but we will publish things and put red on them when it didn't improve and explain it. And since nobody else in our market is still producing results like this, it's pretty easy for me to say we're outperforming every delivery system in the market, because if they were close, they'd be sharing those kind of results.
Could you just give us a couple of headline results that you talk about, just to give an example?
You know, our
talked about last night, like some of the obstetric results and some of the infection results.
In the last 2.5 years, we got serious about early inductions of labor. There's been data coming out of Intermountain probably 10 years ago about the decrease in neonatal complications if you don't induce labor before 39 weeks. But it took a business coalition, the Leapfrog Group, and the March of Dimes, whose mission is to decrease birth defects, to kind of shame us. And about 2.5 years ago, they had a press conference and talked about it. So I asked the question of our data team, how are we doing? And I was really embarrassed. Their goal is that early induction should be less than 5% that don't have a medical indication. And we were at 15% across the system, and one of our hospitals was at 25%. And, you know, granted that some of this is driven by patient preference, and the more affluent patients like to, you know, pick when they can have their baby and customize, and the obstetricians cater to that because it's good for word of mouth. Well, we sat down with our obstetricians and labor and delivery nurses, looked at the evidence, put together a guideline for Advocate, and it's part of the scoring and pay for performance. So we ended 2012 at 1.6%, with 2 of our hospitals at 0. Midway through the year, I got complaints from the president of our biggest hospital that his neonatal intensive care unit had a low census and that we were hurting business. And that's absolutely true. And you know, I'm happy to stand up in front of any of our audiences and say, but this is absolutely the right thing to do for our patients and for the community. With that, but you know, I think the literature says it takes 17 years for physicians to fully adopt evidence-based practices, and the reality is most of the time the evidence changes in those 17 years, so we never get it. So I thought this was a really great accomplishment, that over the course of 2 years, with a little incentive that we're going to measure it and display it, and there'll be a few dollars attached to it, that we essentially hardwired it in and have moved forward.
So I want to go a little bit deeper now into how one does that. And let's talk about some of the, you have a lot of physicians that practice their own way for a variety of reasons. For the most part, what they believe to be good reason. And yet you're able to change the result of an organization. So tell us a little bit about how one goes about doing that.
You know, the things that I've come to appreciate, it's culture, and culture is the way you do business, and our culture's evolved, and for others to emulate what we do, they've got to create an appropriate culture. It's infrastructure, and we can talk about some of that. It's pay for performance or incentives, and it's transparency, and it's kind of a circle, and they all connect with that. But one of the things that we think is important, healthcare is local, and each of our 11 hospitals has a different culture to some extent. So we have perpetuated physician hospital organizations at each of the hospital campuses. They elect a board. It's half physicians and half hospital administrators, and generally we have one system executive on each of the local boards. They have a manager and they have a medical director who is a practicing physician who spends half time as medical director. But the clear criteria is that somebody who the great majority of the physicians respect for their clinical skills, and they're a good communicator and leader. So that's kind of the high-level, basic local infrastructure. Over time, we've moved to do almost everything at the system level. All the real authority is at the system level board, but you don't give out commands at that meeting and expect the 4,000 doctors to move. But when their medical director and the department chair at their site comes to see you and says, you're an outlier, and this is what we're trying to do, and let's have the conversation and explain what you're thinking, because sometimes outliers are really ahead of everybody else, and we can learn, and we need to modify our criteria with that. We take the perspective that we can help virtually everybody improve their performance by giving them feedback and data, and sometimes it comes down to redesigning practice flow on ambulatory conditions. We've learned that the practice manager probably has a bigger influence than the physician on a lot of things. So we meet quarterly with the practice managers, and for our independent practices that are 1, 2s, and 3s, which is the great majority of the network, those practice managers are lone rangers. They don't have a human resources department. They don't have organizational development. They've hitched their careers to a physician, and we actually fill a lot of those gaps, and they really have come to appreciate that coming quarterly and learning about population health and what they can do to help their practice score even better. There's a whole lot of pride with that. And then as we've evolved from sharing the aggregated results, we started to then, internally share the results of the different physician hospital organizations. And there's a healthy competition. Everybody wants theirs to be at the top, and I can remember 5 or 6 years ago, our big medical group has historically scored the best, but one of the PHOs said, you know what, we're as good as those employed doctors in the medical group, and their board and medical directors set out to prove it, and they actually tied the following year, so they shattered the myth that you have to be employed and in a big organization to do that with it. And then one year, one of the sites had the great idea that let's put pictures up of the doctors who scored 100% at the end of the year in the mailroom. And, this is like kindergarten. So needless to say, people were feeling really good. And then the people who scored 97, 98 called and complained and said, well, we had a really good year. Shouldn't we get our pictures up? Everybody wanted to be at the top of the class. Then the other sites copied that. And then the next step in the evolution was to show the physicians how their individual score compared to their specialty across the network. And the last step has been to let all of our physicians see all the individual physician scores and practice scores unblinded. So, if you're a primary care doctor and you want to know how the surgeons that you work with perform on our measures, it's there, it's online, it's updated in real time, so there's no surprises. We aren't sharing that level of detail to the general public yet. I think it's just a matter of when that's going to happen. with it, and our network is going to be a whole lot more comfortable than places that haven't been on that journey.
And what is your theory about what can be validly measured at an individual level versus things that really can't be done at an individual level?
One of the things that we did back in 1993 as we started the journey, no, 2003, not 10 years ago, not 20 years ago, because clinical integration had to show that there was group effort. The original incentive distribution that we put together had 30% of the dollars tied to group performance, and by group we meant the local physician hospital organization, and 70% to individual, although individual would be a primary care practice. As we started to think about it, one, we didn't want to get into the argument that my partner saw the diabetic patient when I was on vacation and who gets, dinged or bonused for the good results. So it's teamwork in the practice. But we also, both to satisfy the regulators that this took a group effort, but as you think about it, diabetic patients will see a primary, they'll see an endocrinologist, they probably see a retinologist in our network. Women might see a gynecologist. If they have any kind of complications, it could be a nephrologist or a vascular surgeon. They all need to be accountable for their hemoglobin A1C and their LDL and all the other things that are evidence-based. So we made that a group incentive. And the results reflected the performance of the PHO. It didn't matter who measured the hemoglobin A1C, but we wanted everybody to know that when Mrs. Jones comes in and she's diabetic, you need to check the registry and see what's missing. And we had some, fascinating discoveries. I do dinners with the rank and file doctors to try to stay in touch with what's going on. And a few years ago, we were at dinner with a group in the community where I used to practice, so I knew most of them. And I always ask the question, what don't you like about the program? And what's the hassle factor? And the ophthalmologist on my left says, why do we have to be accountable for documenting smoking cessation? And he happens to be the person who takes care of me and my family. And I'm taking a deep breath and I'm thinking about the answer. And the internist to the right jumps in and he goes, Jeff, when you tell Mrs. Jones that if she keeps smoking, she's going to go blind, you have a bigger impact on changing her behavior than I've had for the last 10 years. I didn't have to say a word. So the next year when I went in for my routine eye exam and refraction, they give you a bunch of papers to fill out while you're waiting because we've got the HIPAA forms about privacy that always have to get signed in your insurance form. Well, there was a new form with some medical questions, and the first question was, do you smoke, yes or no? They changed their office process to make sure that they were capturing the information. Now, it didn't take the doctor any time, except if the answer was yes, he needed to have a conversation. But those little subtle things that it really takes a team to manage chronic disease, and that's the way it's moved forward.
That's a great story. Take some questions from the audience.
I've got Dr. Matt Morgan here before he goes back and saves a patient's life here.
Thanks, Anton. That was a great presentation. Matt Morgan from Mount Sinai. I have a question about the individual incentives versus the group incentives, because I'm sure, like your organization, our organizations are really focused on building teams at the point of care and striving towards high performance. And so, for example, if I was going to come and work as a hospitalist at your organization, what part of my salary would be based on showing up and doing the work versus actually achieving certain outcomes? So what was the split there? And then how do you provide incentives to teams? So let's say that I'm part of a hospitalist team looking after 100 patients in general internal medicine. How do you incent that team?
So the first part, the actual dollars, even now as the program's matured, and we distributed over $90 million to physicians last April. In the aggregate, for most of them, it's less than 10% of their income. For some of the primaries who have big panels and who really score high, they could get 60 to 80,000, and median income could be 200 to 250. That's substantial, and it really has allowed primary care physicians to invest in technology and to redesign practice, and to allow some of them to stay in small practices because of the economics. But for a high-earning subspecialist in our country who could make $400,000 or $500,000, getting a $30,000 check, you're not going to throw it away, but it's not the end of the world. But so for hospitalists, and most of our hospitalists rotate. You might work 5 days or 7 days, but Mrs. Jones might be in 9 days, and then your partner takes over. So we measure for the group. We're looking at length of stay, readmissions, some of the hospital requirements that we have to report for Medicare on process measures for things like CHF and infections. We look at our emergency physicians as a team. One of the measures that the federal government has started down was aspirin on arrival for an acute MI. And as we looked across our data, even with our big sites, there might be 70 or 80 AMIs in a year, and each individual ED physician might treat 2 or 3. So it's not valid to measure for, by physician. We measure it for the department, and it's their job to have the process hardwired, because the reality is usually not the doctor who's given the aspirin. It should just happen as part of the protocol. The other interesting thing, I'll divert to another story that really helped crystallize some things with group and individual. We learned that for some of the high-earning specialties, the referrals were more valuable than the dollars, and we made group incentives to engage the primary care physicians. So we needed to work on improving radiology turnaround time. And I don't know if there's any radiologists in the room, there probably are. Our radiologists make really robust incomes, and we had more complaints when we announced that we were going to measure turnaround time for mammography and other images, but it's a huge issue. My wife used to complain bitterly every year, how come we can't get the results, and I could go into the system and get them, but she wouldn't hear from her doctor for a week or two with that. And yet we knew there were places that would have results that day, if not when the patient was there. Well, the radiologist had every excuse. We don't have enough transcription, we don't get the old films, da-da-da-da-da-da. I had more noise about this measure than any measure, but we tuned it out and said, this is for patients, and our primaries really are bearing the brunt of it. But we made it a group incentive. So at the end of the year, all but one of our hospitals had dramatically reduced turnaround time. We were under 8 hours on average. It was really humming. And the one site was still up above 24 hours. And their local PHO board met and reviewed the data, and they said, gee, that cost all of us X number of dollars. And the board passed a resolution to send a letter to the hospital president that said, if our radiology group can't meet the criteria this year, we suggest that you not renew their contract. That was in February. By April 1, they were under 8 hours. So the peer pressure in the threat of changing referral patterns, gets it done 98% of the time. Occasionally there's somebody who's just going to say, I don't want to play in this game, and then we have the conversation that you're working in the wrong place.
So what I hear you say sounds like while you do a lot of reporting of individual physician performance metrics, a lot of your payment incentives are actually more at the group level than at the individual level?
About 30% of the dollars are still at the group level. I said in 2003 we split at 30-70. I really thought it was going to migrate every year till it got to at least 50-50. And we had several big conversations at the board level. And the board members said, you know what, it's working, let's not change it. And we've kept the balance, 70 individual, 30% group, and that's enough to get attention on things like that.
And the total size of the incentive, though, is still, you described it as, it's a signal, but it's not the majority of their income.
No, it's a minority with that, but it's a signal. And we give it out once a year. You know, there's debates. Should you give it out quarterly? We came to the conclusion, even though it grew to $90-some million, when you spread it over 4,000 physicians, to give it out quarterly. For many of them, the checks would become de minimis, as well as there's a lot of work behind the calculations, and it's got to be right to the decimal point, because otherwise you're going to have a lot of rework and complaints. So our accounting department, really has a lot of quality control.
Great, thanks. Another question.
Kev, I've got Dr. Reza Deaver, one of our policy experts.
Hi, thanks very much. As you know, patients are not homogeneous, and a small number of people account for a very high proportion of costs. They're also not homogeneous, it seems, in terms of their compliance and whether or not they would indeed stop smoking or that sort of thing. How much in a competitive market is there a tendency to try to not take on expensive or difficult patients and make your metrics by cream skimming?
Yeah, an important question, and we certainly grappled with that because, right from the get-go, the physician said, gee, I have non-compliant patients. And I turned it around and I said, you know what, most of non-compliance is a failure on our part. It's not that there's 20 or 30% non-compliance. You probably can get it down to 1 or 2%. So again, we tried to solve the problem. We've helped with educational material. We do outbound calling. We've held collaboratives to train a physician and one of their office staff in chronic disease management. We invited the lowest performers in diabetes to bring one physician and their practice manager to participate in a 6-month collaborative. We actually paid them for their time because we figured they might not come. And it was a full day, and then it was a monthly teleconference for 6 months and a half a day at the end. And dramatic results with them just making little changes in their office and sharing it with the group and then standardizing it across the network. So now we run a chronic disease collaborative. As we've moved into accountable care and we have much better data for costs both in and outside of our network, 2.4% of the patients, and this is under age 65, spend 27% of the dollars. And the next 9% spend another 27%. So clearly that's where you want to focus. The only problem with that is that's based on claims data. And when you go forward, about half of those patients change every year. Obviously some of them will stay there with ongoing issues, but the lady with breast cancer who goes through 9 months of treatment and then is in remission, in that first year is in the 2.4%, and then they drop off with it. So you have to look at your data in real time, look at leading indicators, like at the diagnosis of breast cancer, we need to be all over that patient with a coordinator, a navigator to get her through the system and make sure that she's getting evidence-based care, and we're dealing with all the issues that crop up with that. So we have now embedded 100 care managers in our primary care practices to focus on the 2.4% of patients and asking our physicians to help in real time before there's even any ongoing data to say, I just saw Mrs. Jones and you know what, I need help with her because we made a new diagnosis and this is going to be a problem. So, another anecdote, my, at the time I think he was 31-year-old son, a tennis player, and he calls me one night from the tennis court. He was in a tournament, and long story short, he ruptured his Achilles tendon. He hadn't seen a doctor in 5 or 6 years, and suddenly he went from at the very bottom of the pyramid where he spends $50 a year, it costs $35,000 for his surgery and his rehab. And most of the expense was in physical therapy because the insurance that he had covered all of that, and he had a very good therapist and a young, attractive female who was working at the fitness center where he liked to play tennis, and she asked him to come 3 times a week. Well, wouldn't you want to go and work out? but we didn't have the insights that the therapy actually costs more than the surgery. So that was an aha for me in terms of there's acute events that for the next 6 or 9 months are going to break the bank. And obviously he could have done a whole lot of that, you know, with a little bit of instruction. And he was motivated. He's doing just fine.
Now, I think one of the other implications of the question is physicians avoiding complex patients in order to essentially game the measurement. You talked about this last night in terms of payments and how that works.
Well, in our capitated system, where patients actually pick a primary care physician, there's a process to discharge a patient. And it can't just be because they're sick or they have complications. In the accountable care organization these days, the patients are free to go anywhere in the network whenever they want. So if Mrs. Jones wants to keep seeing me, short of, you know, her doing something, you know, that violates the rules, that I could, you know, write her official letter saying after 30 days you're not welcome to come back to the practice, she's going to keep coming, and she's on my registry and I'm accountable. We've pretty much gotten over it. We also look at, you know, we serve with our 11 campuses a pretty diverse population. It ranges from inner city, you know, underinsured, poverty communities to affluent suburbs. So we think our mix of patients mirrors Metro Chicago. When we look at our results, while they're not risk adjusted in terms of outcomes, we feel comfortable showing them up against other organizations. Yes, there's places that are in the affluent suburbs and they tend to have a healthier, more proactive population that's going to look a little better, but we've gotten past that. You know, every one of our physicians always, you know, starts with my patients are sicker. And usually when you get some of the data and start to sit down with them, they realize that, you know, I've got a pretty similar mix of diabetes and HIV than the family doctor on the south side has. So get over it and start working on helping them get better.
Great, thanks. Any other questions? Over here.
Yes, thank you. I'm wondering, you've talked a lot about the physician incentives and how you've brought your outcomes up, and mentioned some of the other supports you've brought in. Could you talk a little bit about your distribution of how you spend money, whether it's for infrastructure or other providers, you know, your navigators and practice managers, and how has that changed to bring you to where you are?
Okay, it's good. I think that's a good question. So we were spending about $25 million in infrastructure. And some of this is we have to pay claims on our capitated business. You know, we get a check once a month and we have to pay the individuals. So there's a fairly robust infrastructure to process claims and cut checks. You know, our medical directors, the support staff, the call center, and that. When we moved into the accountable care-like arrangement on the commercial side in January of 2011, we put together a budget and a plan. The embedded care managers or navigators, we started with hiring about 70 of them. We also needed newer IT applications. We needed software for the care managers to track their work. We needed software to take all the claims out of the data warehouse and risk adjust and stratify, so we knew the 2.4% that we're spending 27% of the dollars with that. So we had to, you know, find a vendor who could provide that, and I want to say that was about $3 million. The salaries for the 70 navigators, we ended up adding about $15 million in overhead costs related to becoming more of a population management organization. Put together a business plan and felt that our contract would provide a reasonable enough return that would pay back the infrastructure costs and allow us to create incentives for the physicians in the hospital, and that's the way it's worked out. But, you know, I'm guessing going forward, some of the payers are going to be more open to fronting some of that money, but we fronted it all. which, we like to say that, if you're playing with live ammunition, you get serious. When the doctors are playing with their own money, they're much more focused on making sure that they execute, because the consequences are, we were very clear, there would not be money to distribute next April if we didn't execute. And the good news is last April, the checks were as big as the year before.
So from an insurer's perspective, if you look at the amount of money spent for care for a patient and its distribution, where have you actually found the savings to come from? What are you reducing things or shifting things? Where is that coming from?
One, we were a little surprised that less than 25% of the spend was in the acute inpatient hospital. The hospital executives thought that they were more important and that it was bigger. In the short run, the easiest place to take money out is the acute inpatient hospital, because every day you avoid or every admission you avoid is thousands or tens of thousands of dollars. So we've taken dollars out by better management of chronic disease, so the diabetic doesn't ever end up in the hospital, reducing readmissions, shortening length of stay, and reducing complications. There's a limit to what you can take out there. The next generation is both better management of chronic disease and focusing on discretionary procedures. We do lots of things that have questionable value, whether it's elective surgeries or diagnostics, and really becoming much more evidence-based, as well as getting patients engaged in shared decision-making on various treatment options. The sense is that when you do that well, patients, to the great majority, will pick a lower cost and a less invasive course. But when physicians are presenting the options, their bias is, if I'm a carpenter, every thing is a nail that I want to hammer. In our system up till now, you got paid for hammering, so you wanted to do more of it, and that's what ended up happening.
Thank you.
Over here. Mark Bailey.
Hi, I had a question, two-part question. One of them is about the balance between process indicators and outcome indicators. Obviously, you've given the hemoglobin A1C versus, did you check it kind of question, but I'm just wondering, when you look across your indicators, how many of those indicators would be, does a process occur, and what percentage of them would be outcomes, like how did you do it? And the second part of that question is, how do you integrate, I've been very interested in best practice guidelines, how do you integrate best practice guidelines and evidence into the selection of those indicators?
Okay, good questions. I would say now, probably 50% of the 160 measures that we reported on last year are at least intermediate outcomes. And remember, we're looking at this on an annual basis, and a lot of outcomes are 10 and 20 years. And I think we're going to have a fascinating database, and the researchers are very interested to really look at multi-year with that. We've focused on where you could have the biggest impact because, the message in the beginning, we call this the value report, and that was deliberate. We wanted to be able to demonstrate to the marketplace that we were creating more economic value than we were asking for in the pay-for-performance incentives, so that it was a no-brainer for the health plans to give us that $90 million because they got back a $200 million lift with it. As we went down that journey, more and more specialties would come forth and say, you know what, I don't take care of CHF and COPD, but I'd like measures in my area. And then we've said, okay, come back with some recommendations. And the good news is, in our country, more and more of the specialty societies are coming up with evidence-based guidelines. And then, because we got out of the business of creating the guidelines. We will take things that, have been endorsed by national or international organizations, and then we figure out how to implement them and measure them.
How dependent are you in this effort on the electronic health record and electronic decision support, those sorts of things?
That's a really good question that I get a lot. And when we started in 2003, we did not have any significant penetration of electronic health records. We started with disease registries. Initially, they were pen and paper. Then we used an Excel spreadsheet. And about 5 years ago, we bought a commercial web-based product with it. Over that time, we've implemented electronic records. We've got one of the more robust installations, and I'll say hi to the Cerner colleagues because our inpatient acute hospitals are all Cerner. With that, our ambulatory is a collection of a variety of vendors, so one of the challenges is integration. Up till now, I'm convinced that the registry and making it actionable and helping to train our physicians to use it in real time was 98% of the infrastructure that drove a lot of the success. We're at the point now with a mature electronic record installation that putting in guidelines and order sets can drive and reinforce some of the improvement with that. And then our next generation, next year, we're going to have a new product with Cerner that's going to integrate the registry into the electronic record and allow us to have a lot more customization so that we could potentially expand the registry to lots of really niche subsets of patients. The gastroenterologist last week said to me, we really need to track our inflammatory bowel disease patients, but there's only like 1,000 of them, across Metro Chicago, so we haven't put energy into that, but now we'll be able to support that.
Thank you. Question?
Frank Markel.
In the last month, the New York Times had an article reporting on a journal publication that talked about enormous variability in price for different procedures. I think the methodology was inquiry of the hospitals, the healthcare organizations, on what it would cost. That sounds like a very different world from your organization when you talk about your understandings. I wonder if you have a comment on that study and
It's pretty accurate. We have enormous variation in pricing that's a legacy of our contracts and how we got paid. So you could have an appendectomy at one of our community hospitals and someone else could have it at one of our teaching hospitals and we get paid 3 times as much. It's not right, it doesn't make sense, but we have been unable to rationalize that because the payers have said, well, just lower your price to the community hospital standard, but they aren't willing to acknowledge that the teaching hospital needs to get paid more for something to support the teaching and infrastructure. So these are things that have evolved over probably 2 generations. We think the solution is to move to a global budget or global payment where the unit pricing becomes irrelevant. It's the volume of services, and that's part of the journey that we're on as we move to this shared savings with the commercial payer. We knew that our utilization is much better than the market, and that offsets the fact that some of our sites actually have higher unit prices, and now our overall cost of care is below the market median. Which is good news, is this is going to become more and more transparent.
And I would...
follow-up
go ahead.
question, if I could. How much of that variation is simply price variation as opposed to cost variation?
Well, one of the things I've come to appreciate is that across our country, costs have floated up to what you get paid. There are hospitals that have high Medicaid and Medicare populations and get paid very little and have figured out how to get their costs to a place where they're at least break even. We lose money on every Medicare patient. Probably we get paid today 90% of true costs. In Medicaid, we get 35 or 40 cents on the dollar. But that's because our commercial payers have paid us enough that it offsets it and creates a margin. Everybody in our country who has any focus on the future is all about taking hundreds of millions of dollars of costs out of the organization, recognizing that reimbursement is going to drop down probably at least to the Medicare level, and if your cost position isn't such that you can, generate a margin to create capital, you're not going to stay in business.
And I'll add a couple of things to that. The published research around what it costs if somebody calls is a list price. The reality is that unless you're uninsured, you're going to pay at least half of that number. So the variation on list price is often 10x. When you actually look at what is paid by insurers, there's still substantial variation. It's more like 3 or 4x, which is still a big number. The challenge is that the underlying costs are actually not accurate because there's so much cost shifting, as Lee talked about. An uninsured doesn't pay, and therefore we load up the cost on the insured. And that doesn't really describe the cost of the service. That describes an allocation model. So we're going through that whole discussion. But the research basically says in the States, what's called pricing failures, that's the difference between a $900 and a $3,000 test, is somewhere between 17 and 20% of the explanation for why healthcare costs go up faster than the GDP. So a lot of people are focusing on solving for that problem in one way or another. Another question?
No, I think that's it. Dr. Sachs, it's such a delight that we can share these best practices across the border.
Great.
We send a lot of money and people down to Florida, so we're really pleased to have you
Send them to Chicago.
come up here, spend a little money if you're good. And talking about bringing American expertise in, one of the very next Breakfast with the Chiefs is going to be with Rick Skinner, who is sitting in the audience. But Rick is going to bring his chair and his CEO, and they're going to take a look at those three perspectives and all the data that keeps pouring in and pouring in. So it's going to be an interesting session. I'm not sure if it's the next one or the one after that, but it's soon.
Great. Thank you.
And Accenture and Cerner, thank you again very much for sponsoring us. And Kev, thank you for hosting this. And Dr. Sachs, come back anytime. Thank you very much.
Yeah.